Okay, I will go ahead and get started because at the start of this lecture, I have a little built-in reflection activity, which will allow you to get started in your lunch and get settled in. So thank you everybody for joining us for this session for Critical Care Grand Rounds. I'm going to be talking about nutrition in the ICU today. The outline of this lecture includes recognizing the role of nutrition in critical illness. I'm going to summarize how to evaluate nutritional status, outline an approach to nutritional therapy for the critically ill patient, and then finally, we're going to use a case example to illustrate dosing of parenteral nutrition, in particular TPN. So as you're getting stuck into your lunches, let's take about 3 to 5 minutes here. If you've got a piece of paper or a smartphone, or if you can take really good mental notes, go ahead. But I want to take a pause moment and do a little reflection. I want you to think back to the last patient you admitted or rounded on in the ICU. Did you perform a nutritional assessment? And if you did, what kind of approach did you take for that assessment? How did you determine which mode of nutritional therapy you were going to use? Was it enteral? Was it parenteral? And what did you consider when you were making that decision? How did you determine the amount, when you were going to start it, the rate, the components of this therapy? So take about 3 to 4 minutes, think about it, and then I'd like to hear your thoughts.
Perform nutritional assessments like on every patient. We obviously have lots of different subsets of patients in the unit. We have patients who are intubated, and then with patients who are not intubated and be able to eat on their own. I guess it both have different assessment approaches. When someone is intubated and they don't have any issues with using their GI tract, usually the minute we intubate them, they'll obtain enteral access with an OG or an NG and start enteral feeds. We try to avoid parenteral feeds unless you don't have a functioning GI tract. And usually we begin nutritional therapy depending on what the underlying kidney function looks like, what the underlying diabetes status is, and started the minute you intubate them, unless there's a contraindication, and started at a low rate and up titrate to their goal. Usually we also get a nutrition consult.
So let's dig in on that a little bit. So that's a great big picture overview. So what do you use for your, you mentioned evaluating that nutritional status. So tell me a little bit more about what you use.
I mean, we almost always want to be using their functioning GI tract. So if they're eating and they're able to keep up with their caloric intake, then they'll just get, you know, the regular diet, whether they're diabetic, they need a cardiac diet or a regular diet. If there's any specific, like, they need to be on a clear liquid or some sort. If they're intubated, I guess there's certain things that I know is that they have a AKI or if they're kidney function, then we'll go with things that NAPRO or if they're diabetic, maybe do other like diabetic formulas.
Okay. Any other thoughts? I think
They
this.
also like
Oh.
Are you able to hear now?
Yeah, no, we hear the speaker, just not, if there's any discussion going on in the room, we can't hear.
Oh, okay.
Okay.
Not good for a Zoom meeting.
Okay, thank you for letting me know. I'll kind of repeat. So Hassa was sharing with us that the nutritional considerations include thinking about like favoring enteric feeding over parenteral feeding, thinking about underlying issues like kidney disease and using NAPRO versus if it's a diabetic patient using a different mode of feeding. Any other thoughts on what, or sharing what you include in your personal nutritional assessments of your patients?
Sometimes looking at like their BMI, things like albumin, pre-albumin, to see what their underlying nutritional status might be.
Okay, so
Knowing about history, alcoholic history, if there's major electrolyte abnormalities, that can kind of give you hints there. Especially in terms of like, you know, the typical thiamine, multivitamin, vitamins, things like that. And excuse me, similar to what Hafsa was saying, you know, once you get an OG or NG, try to use that. The other things that I'm typically considering in our ICU patients, if they're on like high dose stressors, and you might want to consider holding off on the tube feeds if they are, and things like that. Those are the other things to have.
okay, great. So for those virtually, the comments were related to thinking about BMI, electrolyte requirements, what else did you mention, Daniel? Sorry. Albumin, pre-albumin, so laboratory factors into assessing the nutritional status is important. How about the how are you determining your amount, your goals? I think you mentioned like a target goal and the rate. How are you in practice managing that?
I'm usually starting with 10 to 20 per hour, advance it by 10 to 4 hours until goal, and usually by the time we get close to 30 or 40, nutritionist commented on.
Okay. So the comment was starting at 10 to 20, advancing every 4 hours or so. When usually when you're hitting about 30 to 40 mils per hour, you have the assistance of our nutritional services. I think that's probably just people in the room and people virtually. Is that kind of what you feel practically we do in our ICUs? I would share that sentiment. I think that's what I see happening. So good. So we're going to talk about the critically ill patient and kind of give you a little bit more of a more structured and more detailed and consensus-based approach to how you can take into account these nutritional assessments and dosing of nutritional therapy. So critical illness has phases, okay? So in terms of talking about nutritional therapy, I'm going to divide this into acute and post-acute. The acute phase is really that first 7 days. When talking about nutritional therapy in terms of the guidelines, in terms of studies that are done, they're talking about that first week. The post-acute phase is beyond that. So the acute phase then can be split into early and late. Early, most of the studies have used about 24, 36 hours, less than 48 hours from ICU admission. Some of the specific studies that have looked at intubated patients, or ARDS patients, have taken early as within 12 hours of intubation. And so this lecture is heavily focused on the acute phase of critical illness, and less so on the post-acute phase. So nutrition and the critically ill patient, they go hand in hand. Nutrition is important because, as you can imagine, your energy needs are increased when you're sick. And nutrition therapy is really delivering that balance between energy consumption and meeting the demands. I think I heard somebody talk about how enteral nutrition has a protective effect on the gut as well. And that is a well-known and established thing that we take into consideration when looking at and emphasizing the importance of nutrition in the critically ill patient. Part of the reason why is that the acute phase of critical illness is really a phase of hypercatabolism, and it leads to energy debts. And in this phase, your body, to compensate and meet that energy debt, is really breaking down protein. So amino acids are being mobilized from the muscle, and that leads to that acquired sarcopenia. So very early on, within that, if you talk about acute phase of critical illness being that first week, you can see how weakness, frailty, the sarcopenia, the wasting, sets in fairly early. Critical illness also has an impact on the gut. It results in gut dysfunction and dysbiosis. Why that's important is because that loosening of the tight junctions of the epithelial cells within the gut, it can open the body up to translocation of gut bacteria that further accentuates inflammatory responses. Worsening inflammation is going to lead to continued organ dysfunction. Beyond this acute phase, so beyond that like first week or so, where the body's mostly in a hypercatabolic state, it then enters an anabolic state. And so you can imagine why that's really the phase where trying to meet your nutritional needs is going to be important. In 1942, Cuthbertson described a model of metabolic stress metabolic response to traumatic stress that occurs in the sort of ebb and flow model. So in that first phase, if you talk about resting energy expenditure, he described an ebb, meaning a dip in your energy requirements. But then beyond that first phase, you can see this flow, an increase in the energy requirements. Now, this in vitro model really has not been replicated in the body. Researchers really have struggled to identify a clear course of how energy expenditure varies in critical illness. And so the current concept really centers around how we have a basal energy expenditure. And this energy expenditure has phases in critical illness. That's this gray line up here. You can see it increases in the early acute phase, dips a little bit, and then continues to increase. The natural homeostatic responses of the body's response to that is to endogenously increase energy production. And in this phase, interestingly, it seems that if you add exogenous energy, it doesn't actually seem to make a difference. That endogenous energy in that early phase seems to be adequate to meet our energy needs. So it's energy expenditure. So energy expenditure is total energy expenditure, or TE, can be broken up into two different phases. There's resting energy expenditure, and resting energy expenditure is made up of your basal energy expenditure, as well as any diet-induced thermogenesis. And there's also activity-related energy expenditure. When we talk about critical illness and nutritional evaluations, We're really focusing on this resting energy expenditure. Clinical conditions impact resting energy expenditure in different ways. So take, for example, clinical conditions like sepsis or burns. I think all of us can understand how that would increase your resting energy expenditure. It's an inflammatory phase type of syndrome. Hyperthermia, hyperventilation, metabolic acidosis, inflammation, obesity, overfeeding, agitation, stress. These are all increasing your resting energy expenditure. On the other hand, deep sleep, coma, general anesthesia, sedation, hypothermia, hypothyroidism, metabolic alkalosis, paralysis, starvation. These are all conditions that will decrease your energy expenditure. One of the great debates in nutritional therapy in the past has been this concept of, do we underfeed or should we overfeed? I showed you like the initial Cuthbertson model about metabolic stress, where there was this ebb in the energy expenditure, but then a flow where it increased significantly. So the question was, is it better to overfeed and provide extra energy for the increased metabolic needs, or should we just more underfeed? So is this energy deficit concept, is it adaptive versus will it result in impaired immune function by the underfeeding and hypocaloric nature? What is the impact of excess energy? So if you're overfeeding, you can in fact cause hyperglycemia, hypercarbia, an increased risk of refeeding syndrome. Nitrogen balances in protein, is a positive nitrogen balance in protein impactful on outcomes, clinical outcomes? Well, there's a theory that excessive protein actually suppresses autophagy versus a negative nitrogen balance, which on the other hand may worsen your clinical outcomes. So what is the right answer? What seems to have panned out over the last couple of decades is a favoring of hypocaloric versus isocaloric, not overfeeding. So not hypercaloric, but err on the side of more isocaloric and hypocaloric. There's no clear benefit of hypocaloric versus isocaloric, but generally the guidelines in acute phases of critical illness will favor hypocaloric. So how do we determine your energy requirement? It's important to establish this goal, because when you're just prescribing nutrition therapy, you want to understand what that goal target is. The gold standard for measuring energy requirements is actually indirect calorimetry. Does anybody want to take a guess at how many ICUs across the world actually have indirect calorimetry? Zero, 12. Any other numbers? Give me percentages, because it's the survey was like 7,000 ICUs. 1% is what I heard. Okay. 10, 7, 3. Who said 1? You're the closest. So Haaland et al. Did a survey. Now, the survey is about 10 years ago now, and they surveyed 7,000 ICUs around the world. It was 0.5% that had indirect calorimetry. So it's not always the most practical approach, but it is the gold standard. So what is indirect calorimetry? Taking a step back, direct calorimetry measures heat production. And it establishes your energy production based off of measurement of that heat production. The indirect calorimetry measures your respiratory gas exchange to estimate your energy expenditure. The idea is that the energy produced must equal the energy consumed. So if you take your consumption of oxygen and you measure your production of CO2, you should get a sense of what the energy expenditure is. Indirect calorimetry can be applied to both invasive and non-invasive mechanisms. And the technology has improved significantly over the years. In fact, there is one device called the QNRG, which has been tested for accuracy with FiO2 ranges of 0.2 to 0.7 FiO2 0.2 to 0.7. And it can be used both in the mechanically ventilated and spontaneously breathing patients. So the technology has improved. In the mechanically ventilated patients, the device would be essentially hooked up to the inline, and it's measuring the gas exchange. In the non-invasive approach, you have a kind of a helmet, a hood that creates a somewhat closed system, and again, measurement of the gas exchange. The measurement outcomes are your VO2 and your VCO2. Those two factors can be used to calculate the respiratory quotient. You've heard of the respiratory quotient. Depending on the substrate, that quotient can vary. So for example, if you're talking about glucose, the consumption and production ratio is 1, whereas in protein, it's 0.8. In fat oxidation, 0.7. So use the respiratory quotient of 0.8 is for a mixed oral diet, essentially. So once you get the measurements of the VO2 and VCO2, they're substituted into this formula. It's the Weir's formula, and that gives you your resting energy expenditure in kilocalories per day. So like I said, only about 0.5% of ICUs have indirect calorimetry at their bedside available. So how are we going to determine resting energy expenditure? Well, here are some alternatives. So there are weight-based equations and there are predictive equations. But if you look at the predictive equations, the accuracy rate, not so great. The highest accuracy rate is about 55%. So if you had to choose between a weight-based versus predictive equation with the poor accuracy rate, the consensus guidelines actually say, you know what, the weight-based equations are a little bit simpler. They're easier to do the math. You can apply it at the bedside. So preferentially, perhaps use the weight-based equations. Of the predictive equations, the Harris-Benedict and the Mifflin-St. George, they are derived out of normal populations, non-hospitalized, non-critically ill. The Penn State, Swenemer, and Ireton Jones were derived in hospital-based populations. A further alternative that's a little bit more accurate than the predictive equations and the weight-based is actually a ventilator-derived VCO2. So Staple and their group, and her group, did this study, ventilator-derived carbon dioxide production to assess energy expenditure. These are used to servo eye, and this was a study conducted in 2015. They ended up screening over 1,000 patients. It was 1,172, and only 84 met their inclusion criteria. But they were able to use the servo eye's output of VCO2 and substitute it into the formula. And they found a systematic error of only 141 kilocalories per day over indirect calorimetry. So just taking a step back, what they were comparing was indirect calorimetry to the ventilator-derived VCO2. So that's a relative error about 7.7%. So when you compare that to the predictive equations that have very poor accuracy rate, a little bit better. A simplified equation for this is that resting energy expenditure is equal to your measured VCO2 times 8.19. And the European nutrition guidelines actually recommend using that if you don't have indirect calorimetry available. Questions on estimating the energy expenditure. Anybody applied a weight-based formula recently? It's been a while since I did as well, so you're not alone. So when it comes to nutrition studies, the major problem in a critically ill patient is that there's a large heterogeneity of the population. So it's a little bit difficult to derive exact recommendations from a lot of these older RCTs perhaps, or even meta-analysis that are now over 10 years old. The observational studies, they have some inherent bias. And so if you look at individual studies, there's a lot of variability in the outcomes. And so most people end up relying upon the consensus guidelines of major societies. In the United States, ASPEN and the Society of Critical Care Medicine combined forces to publish nutrition guidelines in the adult critically ill patients. The last publication of this was 2016. The European guidelines are ESPEN. Their guidelines were last published in 2019. They did put out a task force recommendation for COVID-19 that is in print, I believe, recently. And then the Critical Care Nutrition Network, that's the Canadian group. But if you look at all of these guidelines, in the large part, they actually all mirror each other. And there are a couple of variations. I'm mainly going to focus today on the ASPEN's SCCM and compared to ESPEN when needed. But I just want you to know that there are critical care guidelines for nutrition therapy. Okay, so we're going to move on to determining nutritional status. So evaluation of the nutritional status is a multi-pronged approach. You got to take into account the caloric intake. You got to think about, has there been weight loss recently? Is that intentional? Is that unintentional? Loss of muscle mass, loss of subcutaneous fat, local generalized fluid accumulation, diminished functional status. So a lot of the comments I heard during our reflection were related to how you're incorporating that in determining what type of therapy you want to deliver. And I'm going to encourage you to take a step back and think about this in terms of when your patient first arrives and you're admitting your patient, or you're thinking about how do I need to prescribe that nutritional therapy. Take a step back and think about the nutritional status of the patient. And here is really, we're talking about malnourished versus not malnourished, really effectively. I heard some of these elements that you consider into making that determination. So laboratory, there's albumin, there's prealbumin, there's transferrin, CRP. Can you tell me some limitations of these in the critically ill patient? These reliable numbers? They're not, because they're all acute phase reactants, right? So already you've got a limitation here for your critically ill patient. What about anthropometrics? So assessment of muscle mass and subcutaneous tissue can really help you determine malnourished versus not. Hand grip strength has actually got good correlation. What's a challenge for anthropometrics in your ICU patient? Intubated, sedated, not easy to move around and measure things, right? They're not going to get up. They're not going to be able to give you hand grip strength, because even if they're not intubated or sedated, they're critically ill and they're going to have factors that may not give them the baseline strength. Imaging techniques. So CT actually is a good tool because you can measure muscle mass. What is the challenge in CT for your patient who's just arrived to the ICU? They're too unstable. They're hemodynamically, they're challenging. So you're not gonna, that's not your priority, right? You don't want to send them to CT just for a nutritional status evaluation. Ultrasound is actually an emerging technology. And bedside ultrasound measurements of muscle mass have been used, and they're currently being derived in validation studies for incorporating those measurements into equations that will help you determine nutritional status. So that is an area of evolving evidence base in the literature that may be useful for us as intensivists at the bedside. Question? Yes, so for those of you virtually, the question was, what is being scanned as part of the ultrasound? It is it's the quadriceps muscles and the adductor muscles, the thigh muscles mainly, that are the studies that I have seen so far. So we've highlighted some of the challenges that can occur with our critically ill patients. They don't fall into these nice little packages where you can check your lab albumin or pre-albumin or transferrin. You can measure out their triceps muscle mass, or you can maybe look at temple wasting, but that's really just one little component, right? So there are some risk scores. The nutrition risk in the critically ill score was developed and validated in 2011 and in further studies since then, validation and further studies since then. It's based on the conceptual model that measures acute and chronic inflammatory states and basically says that you've got to recognize the importance of inflammation and illness severity when you think trying to characterize nutrition status in the ICU. And in we're going to look at the components of the NUTRIC score in a moment, but the higher the score, the greater the mortality and the longer the duration of mechanical ventilation. The original score included IL-6, which is not commonly, I guess, in the modern era of COVID-19, we're seeing more and more IL-6 measurements, but typically that's not a measurement that you were using. So in 2016, there was a modified NUTRIC score that was also validated with similar correlations with increased mortality and longer duration of mechanical ventilation. The components of the NUTRIC score are age, Apache 2 and SOFA, so severity of illness, the number of comorbidities, days from hospital to ICU admission, and then, like I said, IL-6, and with the modified score, you just take out the IL-6. So higher scores, the scores above 6, so 6 to 10, is associated with worse clinical outcomes. So this is your malnourished group. And a score of 0 to 5 is your not malnourished or at low malnutrition risk. In the modified score, removing the IL-6, take 5 as your cutoff, and so greater than 5 is at risk for malnourishment, and less than 5, so the 0 to 4, these patients have a lower risk of malnutrition. The ESPEN SCCM guidelines recommend the use of NUTRIC score or NRS 2002 is another score that's used. There are many of these scores. Some of the others include MUST. I can't think of the acronyms of the others, but ESPEN and SCCM, their consensus was preferentially use NUTRIC or the NRS 2002. The Europeans, however, they had a different take on this. They said, you know what, like even these scores are not necessarily considered gold standard, right? So even these scores have some variation. So they steered away from recommending one score over the other, and they suggested a combination of phenotype and etiology. So a little bit of what you guys were describing of what your approach is. So dividing up into stage 1, moderate malnutrition, and stage 2, severe malnutrition. Interestingly, for the COVID-19 task force recommendations for nutrition, they recommended using MUST or NRS 2002. So these ESPEN guidelines were published in 2019, and then the COVID task force was more recent. So maybe there's an evolution in the way they're approaching. Questions on nutritional assessment before we move on. You can apply the NUTRIC score now. Maybe get a sense. Okay, so and if there are any questions for those virtually, speak up or type it in the chat. So let's pivot into the question of enteral versus parenteral. Taking a step back, the modes of delivery of nutrition can be divided into your standard therapy, and the standard therapy is really IV fluids, the advancement of oral diet, versus nutritional therapy. Enteral, the use of an enteral access device, so be that in nasogastric, nasojejunal, PEG tubes, PEGs, versus parenteral, which is venous access. That can be peripheral or central. Someone had highlighted the benefits of enteral nutrition earlier. And the main benefit is really maintaining that gut integrity. So your intestinal epithelium has different areas that function for protecting our immunity and protecting or preventing the translocation of gut bacteria. You've got your microvilli, you've got your epithelial tight junctions, and then there's a humoral immunity layer under that. So the benefits of enteral nutrition are to maintain that villus height, maintains the intraepithelial tight junctions. And then here, by doing so, you're preventing that translocation of bacteria, because critical illness is a stressful time for the epithelial layer of your intestines. By improving blood flow, you also then induce the release of trophic endogenous agents, which will modulate stress and immune responses and support IgA production of producing immunocytes. Overall, by reducing the inflammatory responses, enteral nutrition here can help you maintain and attenuate disease severity. But why is early enteral nutrition favored? When ESPEN and SCCM, when they reviewed their guidelines in 2016, they conducted their own meta-analysis. And there have been 21 studies that have looked at early enteral nutrition and mortality. And in this meta-analysis, early delivery of enteral nutrition mortality was improved and favored early delivery of enteral nutrition. That's less than 48 hours in these studies. When they looked at infectious complications, there's a similar trend that favored early enteral nutrition. These were 13 studies. So you can see there is heterogeneity of all of these studies, but these were many of the meta-analyses have largely come up with the same results. The approach that ESPEN says, so ESPEN and SCCM, they recommend less than 48 hours. Really, that's when you need to start enteral nutrition. Here's where ESPEN provides us guidance. Early over delayed, there was 100% consensus agreement. So that's within 48 hours. Oral over enteral parenteral when you can. Again, 100% agreement. Enteral over parenteral, as we talked about, 100% agreement. If early oral or enteral is contraindicated, initiating parenteral within 3 to 7 days was only about 89% agreement. Now, why enteral over parenteral? This is one of the studies that kind of helped elucidate that a little bit better. In 2018, Rainier and the group published the NUTRIC 2 trial. It was an open label parallel group study, multi-centered RCT. It was in 44 French ICUs between 2013 and 2015. It took the mechanically ventilated population that was receiving vasopressor support. Sound familiar? A lot of our patients, right? Looked at enteral versus parenteral within 24 hours of intubation. They enrolled over 2,000 patients, so 2410 patients. And during the second interim analysis, the DSMB actually said, stop enrollment. It's unlikely, continue enrollment, it's unlikely to change the outcomes. They found no difference in mortality at 28 days and no difference in infectious complications between the enteral versus the parenteral. Interestingly, there were more GI complications in the enteral group, delayed GI complications. But when you think about mortality and infectious complications, no difference between enteral versus parenteral. So consistent with the recommendations that enteral over parenteral is preferred. What about the level of infusion? Overall, gastric delivery is recommended. Why is that? Because it's technically easier. It's much easier in your experience, in my experience, to put in an NG or an OG tube. As somebody had mentioned earlier, goes in when you intubate the patient. It's kind of become part of our workflow. So you've already got gastric access. There's no difference in the mortality or the ICU length of stay when you compare nasogastric or orogastric to small bowel enteral nutrition. Where there is a difference is the risk of pneumonia. So there's a reduced risk of pneumonia with small bowel enteral nutrition. Largely, the recommendation is to avoid checking gastroresidual volumes. You are training in a period that we've really moved away from that routine check of gastric residual volumes. But in the past, that used to be part of the workflow. And part of that is that the routine checking of gastric residual volumes leads to a lot of interruptions in enteral nutrition and thereby limitation of the amount of calories you're providing to hit your target goals. Gastric residual volumes are only one component of signs of intolerance. So combine that data with information about your physical exam. What is the patient doing? Are the bowels moving? Is there vomiting? Is there aspiration? Things like that to make a determination of if there's intolerance of enteral nutrition or not. The reasons that you might consider diverting to small bowel intolerance, small bowel therapy might be intolerance to gastric feeding and or a high risk of aspiration. Is there a question?
So are we also not checking gastric residual volumes when we initially start? I know when we start, we initially check to make sure the patient's tolerating until we reach our goal. My understanding is once we reach our goal, we just stay, we don't touch it unless we have symptoms such that the patient's not tolerating the feed. But when we're initially starting, are we also not supposed to check residual?
So ESPEN and the CCM and all the other nutrition guidelines would suggest avoiding checking that because it is only one component. Now, if you were to use that information and take that in the larger picture and make a determination, it would make sense to kind of hold feeds. But keep in mind that the gastric residual volumes are only one component. And if you are checking that gastric residual volume, really use that number of 500 and not necessarily like 200 or 300. Think about it, like, well, how much does your stomach hold? A lot. And we, in the past, and in your experience, maybe you can share with us like what kind of numbers have been thrown out. But in the past, like 200s and 300s, there was a lot of limitation of the enteral feeds. But really, your stomach can hold a lot more than that. So if you are getting the information about a gastric residual volume, first think about it: is it over 500, less than 500? If it's over 500, go assess the patient and take it in the context of the larger context of the patient. So are there other signs that you can see of gastric intolerance? Factors that make you think about patients who are at risk of aspiration include the inability to protect airway, mechanical ventilation, age, reduced levels of consciousness, poor oral care, an inadequate nurse to patient ratio, supine positioning, neurological deficits, reflux, and even the bolus use of intermittent feeds. But you can see that these could apply to many of our patients. So the general consensus is still start with the nasogastric because there is if you're waiting for like small bowel access, there's often an undue delay that will delay the start of nutritional therapy. So favorite consensus is start with the gastric feeding and then evaluate for tolerance. Any other questions about enteral approaches before we move on to parenteral? So parenteral nutrition, that's your intravenous access. And like I mentioned before, there is central as well as peripheral parenteral nutrition. The difference is that peripheral parenteral nutrition is limited by osmolarity. You really can't deliver more than 900 milliosms through your peripheral route. So that can have an impact on the major nutrients that you're trying to deliver. General approach that's recommended by ESPEN and SCCM is low risk for malnutrition. So example, modified NUTRIC score less than 5. You can wait a week before you even starting to think about parenteral nutrition. Remember, this is your patient who you've already evaluated and determined they're not good candidates for enteral nutrition. If there's a high risk, then you may want to consider it a little bit sooner. But generally, think about, are you able to achieve the caloric goals? And if not, you can supplement parenteral nutrition. The ESPEN study started patients on day 3 with parenteral nutrition. And what they noticed was that these patients had more infectious outcomes and were less likely to be discharged from the ICU and hospital. Another meta-analysis by Braunschweig supported delays in parenteral nutrition in the well-nourished patients, hence the recommendation for that low risk, low malnutrition risk. And Haaland et al. Did a meta-analysis that looked at 4 different studies, and the parenteral nutrition mortality relative risk was 1.78, and that of complications was 2.40 compared to, and this was compared to standard therapy. So there are still some concerns. But on the other hand, delayed nutrition beyond 14 days was associated with greater mortality. So really you've got that, like, you probably got a week where you're okay without starting that parenteral nutrition, but don't delay it up until that 2 week, because you're going to swing the lack of nutrition as an association with mortality. This is an Australasian, Australia, New Zealand randomized controlled trial that I wanted to share with you. They included 31 ICUs. And the population of study was ICU patients who had the relative contraindications to early enteral nutrition, and they were randomized to standard versus parenteral within 24 hours. This again supports the perhaps you don't have to start it that early approach. There was no difference in 60-day mortality. There was a signal of fewer days on mechanical ventilation, but that was really one day in 20 ICU days. So is that clinically impactful? Some would argue not as much. There was no difference in the ICU or hospital length of stay, but there was less muscle wasting and fat loss in the parenteral nutrition group. So again, nutrition does have a role in our critically ill patients, but you may not necessarily need to think about parenteral nutrition very early in the acute phase. Historically, we've always kind of moved away from parenteral nutrition because of the risk of infectious complications. A couple of things to keep in mind is that most of these studies and meta-analyses were done over a decade ago, 10 to 15 years ago. And since then, some things that have changed are there are improved TPN solutions, improved central line care, which overall has reduced central line complications. And another benefit of parenteral nutrition that sometimes is not, we don't think about it at the forefront, is that it allows for better glycemic control, because you can actually administer insulin with your parenteral nutrition. So there are some cautions with parenteral nutrition, but it's not all bad. Questions about parenteral nutrition? All right, so yes.
So it's still with the 7-day mark.
Yeah. So about 7 days you want to start. Now, there are some caveats to that. So if you've got a patient who's on parenteral nutrition at home, you want to continue that rather than waiting. But generally, about that, you can have about a week before you need to start thinking about it, parenteral nutrition. Now, if you've got your high-risk malnourished patient, you may not want to wait a week, right? Because the malnourishment itself carries mortality risk. So that may be more of a 3 to 7 day period. So dosing, first thing, so the approach to your critically ill patient, start by using a weight-based formula to determine your total goal. You want to try and use the dry weight of the pre-ICU weight when it's feasible. For BMIs of 30 to 50, you can use the actual body weight and then use an 11 to 14 kilocalories per kilogram per day to determine your resting energy expenditure. But if it's a BMI over 50, use the ideal body weight and then use more of a 22 to 25. Hypocaloric nutrition is favored over isocaloric and hypercaloric. ASPEN and SCCM vary a little bit in their recommendations. So ASPEN and SCCM says 80%, ESPEN says 70%. Importantly, account for additional energy. So A lot of our patients are on dextrose-containing solutions, lipid-based medications such as propofol. You need to account for those when you're prescribing your nutritional therapy because they are all providing energy. Protein is delivered at 1.2 to 2.5 grams per kilogram per day. ESPEN recommends just a standard 1.3, but ASPEN and CCM gives you a range. Some special considerations, so BMI 31 to 40, use higher protein. The weight in your obese patients is really, it's not your organs, it's more adipose tissue, right? And so protein, a higher protein content. BMI over 40, think about 2.5, burns 1.5 to 2. CRRT, your amino acids get sucked into the circuit. So you actually lose some of the protein that you're delivering, especially when you're delivering parenteral nutrition. So you want to consider an increase. There are some studies that have shown that it's the membrane, the amino acids lost in the dialysis membrane are up to 17%. 15% is what one of the hospitals in Miami is using. But ASPEN SCCM doesn't give you an exact percentage. What they just recommend is limit it to a maximum of 2.5 kilograms per day. Just to be aware that somebody who's on the circuit, that the membrane is going to consume some of the amino acids. Lipids, generally you want to limit your lipids to less than 1 gram per kilo per day. Account for exogenous lipids, so that's propofol. Propofol gives you about 1.1 kilocal per mil. So that's quite a bit if you think about the high infusion rates that we end up using in some of our patients. There are different lipid formulations, and one of those includes soybean, oil-based, and ASPEN and SCCM just says generally in the critically ill patient, avoid it in the first week. Part of this is because this is a pro-inflammatory agent. If you have a concern that your patient has a fatty acid deficiency, you may want to include it, but use a maximum of 100 grams per week and divide it into doses per week. The total volume in a stable patient, total volume per day, you can use an estimate of 30 to 40 mils per kilo per day. But in the critically ill patient, there's a lot of exogenous volume. Really, you want to use minimal amounts to deliver the adequate amount of macronutrients. So I'm going to go through a case study here. It's a 35-year-old female, and I'll just kind of take you through it because the hybrid learning environment doesn't really work well for group activities. So I'm just going to go through the case. It's a 35-year-old who has cerebral palsy, global developmental delay, and she's got recurrent bowel obstructions and poor tolerance to enteral feeding at home, but was continued on enteral feeding. So she's admitted to your ICU postoperatively. She had extensive adhesiolysis. There were a lot of complications. The abdomen ends up being left open and the bowel is in discontinuity. Her NUTRIC score was 9 on admission. She's 65 inches, 50 kilos, and she came to the ICU with a central line that was placed in the OR. What are you going to do? Do you want to start TPN? Why? Okay. Malnourished. NUTRIC score of 9, right? So she's malnourished, she's behind. So great, start TPN. When are you going to start TPN? In this case, because she's malnourished, I think it's reasonable. You already know that she's had some enteral feeding issues at home. She's got a NUTRIC score of 9, bowels in discontinuity. Probably reasonable to start now, but when you start now, you want to start low, hypocaloric, and even like at a rate 50% even, and starting and building up slowly. So here are her labs, generally okay, creatinine's okay, 0.4, sodium's 136, potassium's 3.6. At your institution, you have for your parenteral nutrition, you have 70% dextrose solution, 10% amino acids, and a 20% lipid emulsion that comes in either 100, 250, or 500. How will you determine your TPN energy dosing? What's that? So Harris-Benedict has poor accuracy, was also derived and validated in your normal population. So the guidelines would say go by more of a weight-based. It's simpler to use, and if you're going for hypocaloric, so I suggest like a 20 kilocal per kilogram per day. So 50 kilo patient, that's 1,000 kilocalories per day. You want to start at about 80%. That's your total energy expenditure, or resting energy expenditure rather. So you want to have a goal of 80% of that. That's 800 kilocalories. Protein target, 1.2. You may even want to go a little bit higher knowing her comorbidities and her illnesses, but if you take 1.2, the simplicity of math, that's going to be 60 grams per day. Protein is, the calculation is 4 kilocalories per gram. So to determine your energy from protein, that's going to be 60 times 4, 240 kilocalories from protein. The lipid target. Now, in the first week, it's okay to avoid that lipid target. You have to take, and especially if you're taking into account propofol, you really don't need the lipid. But if you were to use the lipids here, it's a 20% lipid emulsion that's available. It's essentially per percentage, it's 1 kilocalorie per mil, so 10% would be 1, 20% is 2 kilocalories per mil. We have a choice of volume. Let's pick the 100 mil to keep the volume minimal. That gives you 200 kilocalories from lipids. How do you determine the dextrose? Well, it's what's left over. So you know your total kilocalories, your goal. You calculated the protein, you calculated the lipid. So as a reminder, you calculated 80% of 1,800 is your goal. The protein was 240 and the lipids were 200. So what's left over is 360 that you can get from dextrose. To determine the grams, dextrose is 3.4 kilocalories per gram. That gives you 106 grams of dextrose. That in the D70 solution, 70 grams per 100 mils is the D70 solution. That gives you 151 mils of dextrose. Final thing you got to do is make sure that the glucose infusion rate stays below 4. And there's a math there. 1,440 minutes are in a 24-hour day. So if you take, you want to keep this glucose infusion rate less than 4 milligrams per kilogram per minute. The final prescription really is your dextrose and amino acids. We would also put in lipids if we choose to. That's your 20% twice a week, split that volume. ESPEN gives you some guidance. If you look on there, ESPEN parenteral nutrition gives you kind of a walkthrough of the electrolytes and the minerals that you can include. At Henry Ford, a couple of things that you have to keep in mind. If you want to put in parenteral nutrition, get it in Henry Ford Hospital before 1 o'clock every day. Say for Macomb, it's 4 o'clock. Each institution has its own, its pharmacy that you're getting the order into. If you don't know which TPN solution or there's a problem with the standard, Clinimex is basically the like default, the first line if you're unsure. But keep in mind, Clinimex only has 4.25% amino acids and it's only 5% dextrose. So the math varies quite a bit. You'll end up getting a lot more volume because of that. All our TPN is done through a company called CAPS, and sometimes there's some issues with like potassium and things, and that's when you can default to Clinimex as well. For specific TPN orders, you have to put in dextrose. You can see here it's the D70, and the amino acid is 15% here. So different from the Clinimex, right? You can select, you have to select the electrolytes if you want, and any additives that you want to include. These are not defaulted. And then you have to set that. The fat emulsion that's available in this hospital is the 20% infusion. There is also a 10%. There's also some of the newer anti-inflammatory based emulsions that are restricted to certain populations, but really not applicable to the critically ill patient. So key takeaway points: nutrition is important. The metabolic response to stress has ebbs and flows. Evaluate the nutritional risk and evaluate it early over delayed nutrition therapy, enteral over parenteral, hypocaloric, gastric first. ESPEN has a nice little bundle for the bedside practitioner that I think it's useful. Walks you through some of the things that we've talked about. It's in the ESPEN SACM guideline that I sent you all. Any questions?
Did it differ between vasopressor doses on mortality, things like that?
Excellent question. So consensus guidelines is if you've got escalating vasopressor dose, hemodynamic compromise or instability, you can avoid nutritional therapy. The only studies that really, the French study that looked at the ARDS population and vasopressors, that's one study that looked at vasopressor, but it was on the, they did not stratify by dosing, but it was in stable or de-escalating doses of vasopressors. But generally, your unstable patients defer nutrition until they've stabilized or are improving. It is disease specific. There are disease specific recommendations. So another disease specific recommendation is the ARDS population. And in that population, it is the outcomes are the same whether you use trophic feeding, that's that 10 to 20 that you guys were talking about that you start for up to 6 days versus you start enteral feeding at 48 hours and escalate up to goal. The outcomes are similar in terms of mortality, infectious complications. So you have like that buffer of 6 days where trophic feeding, but trophic feeding still preferred over no feeding for beyond 48 hours. Any other questions? All right. Anything on the virtual environment? All right, thank you, everybody.